If you've been prescribed medication for your insomnia, you're probably going to have some questions about how it works and what potential side effects might be. Doctors usually prescribe 5 different categories of drugs to treat insomnia. I'm going to talk to you about how you can expect them to impact your sleep and you overall. Hey everyone, I'm Dr. Michael Breus, the sleep doctor. Remember, this is not medical advice, so if any of the information in this video brings up some questions about your medication, please talk to your doctor directly. There are about 5 different categories of ways that people want to use some type of pharmacotherapy to help somebody with insomnia. Historically, we used to use these things called benzodiazepines. Then later on, we started using things called non-benzodiazepine hypnotics. Then we started to understand better how antidepressants, antihistamines started to work, as well as melatonin. And then there are some other things like alcohol, a few things like that. So I'm going to go into all 5 of these categories, tell you the pros and cons of each one. First, we're going to start with the old school therapy, which is benzodiazepines. Now, I want to be clear about something. Benzodiazepines is a category of medication that historically has been used for anxiety. The name of some of these drugs may be familiar to you, things like Dalmane, Restoril, or Halcyon. Even things like Klonopin, Ativan, Xanax, and Valium. All of those are benzodiazepines. The way you can tell is with their generic name, it ends with a PAM. So for example, Restoril is Temazepam and Klonopin is Clonazepam. These drugs fall into a very particular category. And to be fair, it's not necessarily the best category. These drugs are known to have fairly high addictive potential, meaning that your body will have a physiological withdrawal from them when you stop taking them. Also, many of these have extended half-lives, which means it's hard to get them out of your body. And in some cases, it can make you even feel the effects the next morning. Again, these were originally used for people with anxiety. And what they discovered was it kind of calmed them down so much, they started to fall asleep easier. And so they said, okay, let's try using smaller dosages at nighttime and see how it goes. As a general rule, I like benzodiazepines because they're fast and they're effective. But within the benzodiazepine category, there were some problems because of the high levels of addiction, because of the long instance inside the body. Newer drugs were made, and these were called non-benzodiazepine hypnotics. So what was interesting about these is benzodiazepines, not only do they put you to sleep, but they actually change the type of sleep that you get. You don't get the deep sleep, and in some cases, it could even knock out REM sleep. The non-benzodiazepine hypnotics, Ambien, Sonata, Lunesta are some trade names. They're also called Zolpidem and Zaloplan, also known as the Z drugs. These drugs are actually different, but still fall into that category. They're less addictive. In fact, many cases, they're non-addictive. But the biggest thing is they don't change the sleep stages. They don't change the sleep architecture. So when doctors are looking at the benzodiazepines like Restoril versus the non-benzodiazepines like Ambien, almost everybody's going to choose the better technology of Ambien because of, again, less addiction, staying in the system less, all kinds of better technology. Now, here's what's interesting is when you start to look at them, the drugs can be very different. The onset of action is one that everybody really likes to know about, and it's basically the same for almost all of them. Whether you're in a benzo or a non-benzo hypnotic, almost all of them appear to take effect within 10 to 20 minutes. Now, here's a big problem that I see happening out there is many people, let's say you're prescribed this benzodiazepine, they take it and then they go brush their teeth, wash their face, go to the bathroom. 20, 25 minutes, this drug has kicked in. And I've had patients who go to the bathroom and wake up in the morning because they've fallen asleep on the toilet, right? This is not the thing to do. What you want to do is finish all of your hygiene activities, have your medication on the bedside table, take it, turn out the light. That's the best way to do this. It works significantly better in every single case. Now, what is the elimination or half-life? Like how long is this stuff going to stay in your system? Once you start getting into the benzodiazepines, it can be as little as 2 to 5 hours or as much as 36 to 120 hours. So there's a very wide breadth of time that this drug is going to stay in you. Personally, if I had to choose between benzos and non-benzos, most people are always going to choose non-benzos because it's shorter activation life and you don't have to put so much drug in somebody. average amounts of drug you're going to see are everybody should always start at the lowest possible dose, and then it should be slowly increased only by your doctor's permission. Okay, what are some of the side effects and what are some of the problems and good things that happen? Look, benzos aren't all bad. They are hypnotic. They definitely make you fall asleep. They do reduce anxiety. And let's be fair, some of these medications can be great during the daytime at low dosages to help you with daytime anxiety. These are also what are called myorelaxants, which means they relax your muscles. And so they can be helpful for small issues with pain, low back pain, things like that. And there are even some benzodiazepines that are anticonvulsants, meaning they prevent you from having seizure or things like that. The side effects of every benzodiazepine? Well, a good one is sedation, right? Because it actually makes you fall asleep. But there is a problem with many of these benzos, and that's something called anterior grade amnesia. What does that mean? After you take that pill, you pretty much don't remember anything until you wake up. That can be a bad thing depending upon, again, if you take your pill and now you're wandering around the house and doing all kinds of things. Also, we have a tendency to see something called ataxia, which is where there's a loss of movement or ability to fall quite frequently. Also, with benzodiazepines, we see a respiratory depression. This becomes incredibly important when people mix benzos with alcohol. So there are a lot of people out there who will say, oh, I'll have a drink or two with dinner and then I go home and I take my sleeping pill. This is a terrible idea. Number one, if it's a benzodiazepine, you already have lowered respiratory drive or your ability to breathe. Now you add the benzo on top of that, you got a real problem on your hands, right? A lot of people die that way. So this is not something that you want to do. The other big thing is with a lot of benzodiazepines, they lose effectiveness over time. And so people have to keep escalating the dosage. Again, becomes a problem with addiction and how long the medication stays in your body. If you did a meta-analysis looking at benzodiazepines across all things of insomnia, going to be honest with you, they do have a tendency to work. We do see very large effect sizes, meaning it actually tends to work in helping people fall asleep quickly and giving people a little bit more total sleep. It appears to lower the number of awakenings and improve sleep quality. So it sounds fantastic, right? But you're now on a pill almost every single night, and you may be addicted to that pill, and it could have interaction effects or doing other things that are going within your body. I want to be very clear about one point here. If you and your doctor have come to the conclusion that they want you on a benzodiazepine, there's nothing wrong with that. That is a decision between you and your doctor, your symptoms, your tolerance, and what's going on with you. I just want you to have the facts to know what works and what doesn't. There can be a rebound insomnia that can actually occur if you pull yourself off of this medication. This is usually related to the dose and the half-life of the medication. It can be easily prevented by slowly lowering the dose and eventually taking you off. Nobody should cold turkey themselves off a sleeping pill because here's what's going to happen. You're going to be up for 2 or 3 days. I can almost guarantee it. Now, the other thing to remember is you cannot easily distinguish return of original symptoms when you take away the drug immediately. But if you slowly take it away, guess what? The symptoms don't have a tendency to come back. Also, it doesn't predict future pill-taking behavior. So what ends up happening is you have the insomnia, you take a drug, you rip it out from under you. Guess what? You ain't probably going to take that pill anymore. It can vary from drug to drug, and it may not be seen with some agents. So once again, this is an effect, this is a side effect that you could have to deal with or not, depending upon how slowly you come off of the benzodiazepines. Now, there's also benzodiazepine use and abuse. So it's actually kind of rare, but non-medical use is actually seen in the general population. Klonopin in particular appears to have quite a bit of street value now. So abuse risk is actually seen exclusively in polydrug users. So what we're seeing is Klonopin and heroin users. So for example, if you get a benzodiazepine from your doctor, don't tell anyone. I wouldn't tell a soul. Number one, there's somebody who might try to steal it out of your bag or your medication cabinet. But number two, these people who are addicted to drugs are looking for these types of drugs. There is a tendency for people to increase dosage. It's seen in about 5% of patients, specifically with a history of alcohol abuse. Also, benzodiazepines can actually reinforce considerably among drugs, or what actually happens is people end up with bigger drug problems once you introduce a benzodiazepine if they already had a drug problem. So for folks out there who have a history of drug abuse, benzodiazepines and even non-benzo hypnotics are generally not what we would be recommending. Now, inside the non-benzo topic, I've been talking about benzos now. The non-benzos like Ambien and Sonata, there's actually some good data in here. We know that Ambien, specifically Ambien CR, which is the continuous release form, can be indicated for the treatment of insomnia, which is characterized by all the things we've talked about, right? So can't fall asleep, can't stay asleep, things like that. But the extended release formulation actually seems to help because it seems to actually trail across the night and seems to be helpful for some people. This might be a medication that, working with somebody's physician, we might use, again, to break the cycle of the insomnia and then have all the behavioral things with it and then slowly taper the Ambien, because Ambien turns out to be very easy to taper. Also, we don't see a whole lot of decrease in performance after somebody's been taking Ambien. So a lot of the problems that we have with benzos, we don't see with Ambien. A lot of doctors say, I don't like benzos and I don't like non-benzos. The only thing I feel comfortable with are antidepressants. So believe it or not, there are no antidepressant that is FDA approved for the treatment of insomnia. But lots of people still prescribe them because antidepressants do have a sedative and sleep promoting effects. So again, this is not an FDA approval. This is an off-label use that most doctors would actually prefer rather than the addiction of the benzos or having those problems with Ambien. So what do? They actually have some insomnia patients with depression and anxiety. And since there's such a low risk of abuse, and we actually end up putting them on something like this to help them out. I will be honest with you. If you have a patient that hasn't slept well and you give them a pill, whether that pill is addictive or not, they're going to want that pill again and again and again. That's a psychological addiction. And so that's also something that many practitioners don't address but need to be aware of, especially with things like antidepressants. Now, typical antidepressants that might be used are the serotonin-specific reuptake inhibitors. So that's things like Prozac, Paxil, Zoloft. Things like that can actually be very effective. And what's interesting about it is, in fact, if you take some of these medications, if it decreases the depression, guess what? The insomnia just goes away sometimes. So sometimes we don't know which we're dealing with, the chicken or the egg, but in many cases, the SSRIs can actually be quite helpful. Also, there's another class of drugs that are the serotonin and norepinephrine reuptake inhibitors called Effexor. That's actually been shown to be quite helpful for sleep as well in terms of antidepressant. So these are the kind of drugs that you have a tendency to see, but there's also another class, and these are tricyclic antidepressants. So things like Elavil, amitriptyline, doxepin, these are medications that are old school antidepressants, but kind of make you a little bit on the sleepy side. And so sometimes a lot of physicians will say, I'm willing to give you that because I know I can give it to you for extended period of time, no addiction potential, and hopefully it can help you. The biggest one that we have a tendency to see out there now is something called trazodone. Also another one called martazepine, also known as Remeron. These are the two antidepressants that almost any doctor doesn't have a real problem prescribing because there's such a low side effect profile. You can leave people on them for extended periods of time, but you're addicted to a pill for extended periods of time. That might not matter to you. I mean, it might be that you take your 50 to 100 milligrams of trazodone every night before bed. And let me be honest, that's just fine. You can do that for 15 years and be just as healthy. Some people have no problems with it. Some people, however, are not comfortable with being on a medication for extended periods of time. I kind of get it, and want more natural methods. So we're really talking about which level of comfort are you going to be at in terms of which categories the doctor going to put you in. A few other things that people need to know and understand about side effects from antidepressants. Well, number one, nausea and diarrhea come with almost every single one of them. Believe it or not, insomnia can be a symptom of an SSRI side effect. So you need to be careful that you're not trying to fix something and actually making it worse. That can happen where, for example, you could give a patient Wellbutrin, which is very stimulating. They take it at night and now they've got a case of insomnia that's worse, not better. Other types of side effects that we can see, headache is a big one. My worst one though is the drug interactions. So I'm always looking to make sure that they're not on something that's going to be having a problem here. Of course, weight gain can be a side effect of most of these. And remember, with weight gain can sometimes come sleep apnea. So you really want to be careful about that. And believe it or not, in some cases, you can actually have hypertension associated with medication. That turns out to be with Effexor only, but that's something to definitely think about. With the tricyclic antidepressants, it's great because basically they're sedative. Unfortunately, they can give you a dry mouth and a little bit of constipation, There is a decent amount of sexual dysfunction that does appear to occur with tricyclic antidepressant use. So for folks out there, that can be a problem for them. What I oftentimes tell people is, again, this is where you start low and go. And so you're targeting the smallest dosage to really understand those side effects and then move forward. I will tell you that most of the docs out there have no problem prescribing trazodone. It does cause a level of sedation, maybe a little dizziness. But I got to be honest with you, lots of people love trazodone, and it can be one of those things that you can take for extended periods of time. So if it works for you at a subclinical dose, this could be a great one to help break that cycle of insomnia if that's what you're talking about. Remember I told you about Wellbutrin? Well, remember it can cause agitation, headaches, insomnia, weight loss, things like that. So that's one of those ones that you really want to be careful with. And mirtazapine or Remeron actually helps out quite a bit, very similar to trazodone in terms of the side effect profiles, but as a general guideline, it seems to be quite helpful. A lot of people wonder, well, we know that the benzodiazepines affect sleep architecture, and you told us, Dr. Breus, that the non-benzodiazepines affect it less. Do the antidepressants affect sleep and sleep architecture? Unfortunately, they do. What we have a tendency to see is with the tricyclic antidepressants, they lower REM sleep. With the SSRIs, they lower REM sleep. But with trazodone, we actually see a slight increase in REM sleep. And with trazodone, we actually sometimes see a slight increase in slow wave sleep. So a lot of doctors, again, are going to jump to trazodone because, again, it's so much simpler to do something like that than some of these more other complicated antidepressants. Another category that lots of people use and don't even realize that they use it are antihistamines. So if you've ever taken a PM on the side of some type of pain relief, you've probably taken an antihistamine. Antihistamine's mechanism of action is where we actually antagonize the H1 receptor site. And what ends up happening is it starts to produce a decent amount of serotonin and adrenaline. And guess what? Boom, you start to fall asleep. Now, I will tell you, antihistamines can have a lot of adverse side effects. One of the biggest ones is, I don't know if you know people like this, but one of my kids is like this, is when we give them an antihistamine, it makes them agitated, not relaxed. I don't know if you've seen that happen, but it's called a paradoxical effect, and sometimes that can be an adverse effect. Sometimes people can get a little freaked out when they're on antihistamines, a little delirious. Of course, dry mouth, sedation, and grogginess is definitely something that we have a tendency to see. As you can tell, I'm not the biggest fan of antihistamines to help you sleep. Maybe if you're on the road or maybe once in a while, it's probably a decent thing. But this next one is an area that I really like to talk about because so many people think that this is the thing that they've got to take. It's called melatonin. So remember, melatonin is a naturally occurring hormone. It's secreted during darkness at night. There's a broad range of physiological effects that it has. It's an amazing antioxidant, but we do know that it's not great for insomnia. It seems to be better for circadian rhythm disorders. As I've said many times, when I'm going to use melatonin in a patient, they're going to have jet lag, they're going to be a shift worker, they're going to be older, maybe in their 50s, 60 years old, where we see melatonin decline. But as a general rule, melatonin for insomnia is not my first line of defense. By the way, it's not FDA approved or regulated, which means anybody can make melatonin in their garage and sell it at the local GNC and nobody cares. So you really want to look at purity standards and things like that. Personally, remember, melatonin can have all kinds of effects and a lot of people don't understand it, but melatonin can affect antidepressants, diabetes medication, heart medication. The list goes on and on. So don't just run out and grab the first bottle of melatonin that you see, because number one, it probably isn't appropriate. As a little side note here, melatonin is not for children. I've said this many times, but at high dosages, melatonin is a contraceptive. And at high dosages, we're talking about 4 and 5 milligrams. So you do not want to give a contraceptive to a young female developing body at any case that I can think of. So nobody under the age of 18 should probably be using melatonin. Also, by the way, most of those people have about 3 to 4 times the amount of melatonin floating around in their head, so they're just fine. Let's talk about Valerian. Valerian is arguably the number one herbal substance that's been studied out there. And it derives from the valerian root. It is not FDA approved or regulated. It does appear to have a mild hypnotic effect. We don't know exactly why, but it seems to reduce anxiety and reduce muscle. Some studies show that it actually makes it quicker to fall asleep. Your quality of sleep improves. However, oftentimes it's best when used with hops. Good news here is there's no evidence of tolerance or abuse, so this is something that you can probably pick up and give it a try. Alcohol, on the other hand, is considered the #1 sleep aid in the world, and it's the worst one by far. While alcohol does make you fall asleep faster, it does decrease the amount of REM that you have in the first half of the night, then increases it later in the night and produces very shallow sleep. Usually depending upon the dose of alcohol. And guess what? You wake up, go to sleep, wake up, go to sleep. You have crappy sleep. You're waking up to pee all night long. It has a major effect on you. In alcoholics, it actually increases sleep latency. So when you drink, it actually makes it harder for you to fall asleep. And it decreases REM and slow wave sleep. So it's actually one of the ways we can see how alcohol affects you is if you actually have these effects, you could be on that other side of alcoholism. So what is a general pharmacologic approach take a look at? Number one, select the appropriate medication for you and your situation with your doctor, okay? I can't say it enough. Don't take your friend's medication, then walk into your doctor and say, hey, I tried my friend's 5 milligram Ambien, that's what I want. Bad idea, okay? Talk with your doctor, really understand what's going on, understand all the side effects, start with the lowest effective dose. You don't need more, less is always better. Use it at bedtime or later if indicated. And during the therapy, you only want to use it for probably somewhere, I don't know, I would say 2 to 4 months. I've never been able to get somebody off of a medication while doing a hybrid therapy. We're doing behavioral therapy and medication in less than about 3 months. Generally speaking, if you can, we want to keep people on these drugs for somewhere between 30 and 60 days, if at all possible. We obviously want to keep the dose reduced because we don't want them to be groggy the next day. And personally, I would prefer it if people didn't use sleeping pills every night, but more intermittent use because that can actually make them last longer and work a little bit better. And of course, I always combine with behavioral strategies because I think that's really the best way to go. First line of defense, maybe consider a short-acting benzodiazepine receptor site, or maybe consider a low-dose sedating antidepressant, depending upon your comfort level. Third line of defense could be a combination of medications. Again, this is the thing that you talk about with your doctor and get very, very comfortable with it. Combination of non-pharmacologic and pharmacologic methods are always the way that I like to go. But be fair, get yourself a referral to a sleep specialist. You want somebody who knows these medications inside and out and knows the non-pharmacologic approaches, so that way they can give you a hybrid model that can work best for you. So in summary, I gotta tell you, insomnia is prevalent and it is persistent. There are a lot of risk factors out there: your age, the female sex, psychiatric and medical disorders, and the consequences are devastating. When people have severe insomnia, they have an impaired quality of life, they have increased healthcare costs, depression and anxiety, it's everywhere. I've gotta be honest, guys, there is treatment available and you don't have to get stuck on a pill for the rest of your life. So pharmacological approaches are common among physicians, but you might be interested to know there are more effective options that do not require any medications whatsoever. And the best part is that they build good habits that can last an entire lifetime. So for a video on my favorite non-pharmacologic treatments, check out this video right here. This is Dr. Michael Breus, the Sleep Doctor, wishing you sweet dreams.